Welcome to We're on ECMO, an educational series for the extracorporeal community. And my guest today is Julie Pingel, a pediatric pharmacist at Monroe Carell Jr.'s Hospital at Vanderbilt, where their ECMO program is an ELSO award-winning center of excellence. And so, Julie, thank you so much for joining me today. And I've got a couple of questions for you. The first one is that could you give us a crash course on why drug sequestration in the ECMO circuit happens?
Okay. Well, thank you for having me. And first of all, drug sequestration to the plastic part of medical devices is kind of a well-known occurrence. It's my understanding that this happens because of the plasticizers that are used to make the plastic flexible so that it's not rigid. We can have the flexible IV tubing and flexible ECMO circuits. But those molecules actually bind to the molecules of the drug. And so the drug then can get stuck to the circuit. And there are several factors that impact that. Two of the biggest ones are going to be protein binding and the lipophilicity of the drug. So drugs that have higher protein binding and drugs that have higher lipophilicity are going to be more likely to be sequestered in the ECMO circuit.
Awesome. Yeah, thank you so much. And knowing that this happens, what are some of the considerations when dosing like pain medicine and sedation medicine, for ECMO patients? What should we be considering?
Okay. So first off, we need to have a really good understanding about which drugs are going to bind to the circuit more than others, and then have an understanding about when they do. And that's really the only option you have. Understanding dosing adjustments that you may need to make. So first, just looking at the opioids, we have the three most common ones that we're going to use in the pediatric ICU setting are going to be fentanyl, morphine, and hydromorphone. Fentanyl is most places would probably say it's standard of care for first-line therapy for a patient that needs to be sedated with a continuous infusion. But of those three agents I just told you, it has the highest protein binding and the highest lipophilicity. So while that may be first line in some patients, it's not going to be the best option in an ECMO patient. Some studies have reported up to 50 to 70% binding of fentanyl to the circuit. So obviously that makes it not ideal in these patients. But now Dilaudid is less lipophilic than fentanyl and then morphine also. So either of those, morphine or Dilaudid, would probably be a better first-line choice than fentanyl when using an opioid. Now looking at the options for sedation. So our first line drug that we always use in the pediatric population is dexmedetomidine. And unfortunately, it's also very lipophilic and very highly protein bound. So there's not quite as good data on that one as there is with fentanyl, but there is data in the adult population showing that where your standard upper limit of your dose we have to use higher doses in the adult population. And of course, we don't have good peds data for that, but at some point we probably will. So we know we just have to use higher doses of our Precedex, which is dexmedetomidine, to provide the similar sedation in ECMO patients because of that sequestration by the circuit. Unfortunately, we don't have a similar drug to dexmedetomidine in the same class that we can just switch to like we do with the opioids, that maybe it's less lipophilic. It's the only IV option we have in that class. So what we have to do if using higher doses of dexmedetomidine doesn't provide adequate sedation, we may have to add on a different agent like a benzodiazepine. Now, typically we avoid benzodiazepines in pediatric patients because we know it contributes to ICU delirium, and so we try to avoid that. But you do have much less binding to the circuit with your benzodiazepines. The most common one that we use is midazolam, and it only has about 30% binding to the circuit. So you're going to get better sedation with that. Again, we try not to use it a lot, but it might be a good option as an add-on when adequate sedation with higher doses of dexmedetomidine are not providing adequate sedation.
Is there anything that you would say, like the ECMO specialist or bedside nursing or anything should be aware of or looking out for as these drugs are being administered?
Yes. But in addition to In addition to drug sequestration to the circuit, we also have a much bigger volume of distribution when we're talking about a patient on ECMO versus a patient not on ECMO. We have all that extra blood volume that we have to fill up. So it's like a whole extra compartment to fill with drug. So drugs can have a slower onset than what we would expect. It's going to take us longer to achieve a good peak effect of the drug. So that's something to keep in mind. And so that's one thing to remember, that it may take longer for these drugs to work, and we may need some more loading doses of them to really get to a good steady state level before we achieve adequate sedation. And then also, I would say, constantly elevating if the patient does not seem well sedated. So we need to accept that sometimes we may need higher doses than normal, and dosing to a good sedation score and dosing to a good pain score are really good things to follow. So it may take a little bit longer to get a patient adequately sedated, but once you reach that sedation score that you're following, once you get there, then that's a great place to be. But you also need to think about when can we pull back? We don't want to be over sedated either. We don't want to overshoot because we're trying to load up all this extra volume in the ECMO circuit, and now we're there, and now we're over sedated. So I would say following a good sedation score, as always, which I think that's kind of the standard practice in pediatric ICUs now. So following a good sedation score to get to that goal and trying to maintain that goal, and also following your pain scores when treating pain, so that we're really keeping everybody on the same page with what we want our goal to be.
Gotcha. If there is some of that drug getting sequestered in the circuit, is there any chance that like it has like a lingering effect? Like, will any of that come off the?
Yes. Mm-hmm. Yeah, that is a possibility. The data is not as good for that, but there are reports of various drugs where, say, you turn the drug off and then it then starts to leach out of the plastic. So that also can happen. Another thing to think about is with circuit changes. So you may have a patient on finally stable on a good dose, and then you change the circuit, and then it's like you have to start all over again because you have all that new tubing that drug is going to stick to now. So that's another thing to think about.
That's an excellent thought. Thank you. Well, thank you so much for being so generous with your time and sharing. We really believe that this greater education and staying educated, is going to lead to better patient care and better patient outcomes. And so we really appreciate you jumping in with your expertise to share with us today. Thank you so much.
Well, thank you.
If you're watching today and you have a question that you would like to hear answered by an experienced professional, make sure that you reach out to me, Neil, Neil, at ECMOadvantage.com. We'll see you next time. Thank you.